can see the lowering of our arch. Why does this happen? All because of the obliteration of the sinus tarsi. This is happening of the talus on the calcaneus. Here we can see a transverse plane deformity. This is something that an orthotic just cannot fix. It cannot prevent this from occurring. So the whole goal is to stop this excessive motion of the talus on calcaneus, which will then help to eliminate the other soft tissue deformities that are going to happen as a result of this excessive motion. Here we can see our first ray deformity that's happening again as a result of what's occurring in this patient's rear foot. 10 to 15,000 times a day we have this deformity. So this is what I look at on the clinical table is just load the fourth and fifth med heads, and that shows the obliteration of the sinus tarsi. Here's our surgical landmarks. This is the fibular malleolus, and then we have the anterior calcaneal prominence, and our incision is going to be about an index finger distal to the fibular malleolus. The anesthetic mix that I use is a 10 cc syringe with just a sinus tarsi injection. I use 0.5% Marcaine with and without epi, and I also include 1 cc of dexamethasone phosphate into this cocktail, which significantly decreases patients' post-op discomfort. You can see the angle of the syringe that's going obliquely because the sinus tarsi runs from anterolateral distal to proximal medial posterior. You also want to put a little bit of that anesthetic mix up in the anterior talofib ligament area. The incision is 1 index finger anterior to the fibular malleolus, about 1.5 centimeters long. Don't do any undermining. This is the next very important part, which we'll see again in a little bit, is to cut the structures within the sinus tarsi. This will then create nice bleeding edges, so when we insert the stent, the ligament will heal back together around the stent, which helps to incorporate it and help to prevent displacement. After this, then we'll insert our guide wire, and we want to feel the tip of that medially, and remember again of the angulation that we have. Now we go to our trial sizer. Here's the number 6 trial sizer, and you want to again look at your angle, and it goes you should not be able to over insert this. Push it in and then load the fourth and fifth med heads. You'll instantly see the kind of correction that you're going to achieve with the stent. So again, you can just see without the stent in there, we're getting a lot of valgus deformity and excessive pronation. So we're going to keep inserting the different trial sizers until we find the one that gives us that right amount of pronation, which is about 3 degrees. Now you can see with that size 7, we're getting very little pronation and mainly just dorsiflexion. Now again, this is under fluoroscopy. This is incorrect angle. This is going from lateral to medial. That's where the other stents go, and that's why they fail. Hyprocure goes more into the angle of the sinus tarsi, and so it fills in more of the canalis as well as the sinus. So that's where we want to go. So remember that angle. Again, I want to show the trial sizing again. You're going to push it in till the sizer just won't go in anymore. And we're going to stabilize that fourth and fifth med heads and just push on the foot as hard as you can. And you'll see how much correction you're going to achieve. The overall goal is, remember, thou shalt not varus. So just as long as we have some pronation, that's okay. So again, here's the size 7. The most commonly used stents on the market are the size 7 and 6. So just remember that if you're up around the 9 or 10, then something most likely is wrong. Although you will need to use those once in a while, but not too frequently. So here's our number 6 stent. We're going to put it on the guide wire, put the driver on top of that, and load it into the area there. Push it into the sinus tarsi. Remove the guide wire, remembering the angle, and just push it in until it won't go in anymore, and give it a couple of spins to lock the threads into the soft tissue. It's not going to tighten down. So again, here is the stent going in. This is lateral to medial, so this is an incorrect angle. What we want to do is just angle that more posterior, aim it into the head to the posterior aspect of the medial malleolus, and you push the stent in until it won't go in anymore, and you're done. So you should always check these under fluoroscopy as well to make sure that you've seated it correctly. So again, incorrect to correct. So we just really want to bury that stent in. So here's a live surgical video, and again, you can just see how much hyperpronation we're getting, leading to the patient's bunion. I've drawn our landmarks. We're going to make our incision about 1.5 centimeters long. We're not worried about cutting any structures in this area. Don't do any undermining of the skin. Just cut the skin. Go right to your curved tenotomy scissors with the curve heading posteriorly. Do a little bit of blunt dissection, and we're going to cut those interosseous fibers so that our stent can go into the canalis, and then those fibers will heal back together. It's not a problem. You can feel the tip of the scissors medially with your other hand, so that way you make sure that you've cut those fibers all the way through. If you don't cut them completely, then that can lead to the stent displacing. So again, we see because of that forefoot valgus, the ground just keeps pushing up on her first ray, and there's our bunion deformity. So I do these prophylactic for patients with these bunions. I do this procedure, and we actually see a decrease in the IM angle. So we might not even have to do a bunion surgery on her. Again, here's our size 6 trial sizer. We're going to put it on the guide wire, aim posteriorly to the medial malleolus, push it until it won't go in anymore, and you can just see how we're loading the 4th and 5th metatarsals, and we significantly have decreased that excessive pronation that was occurring in her foot. So we're going to pull that one out, and then we're going to go for the size 7 and just see what kind of correction we're getting with that. If it seems that there's not much of a difference between the 6 or 7, I always feel it's better to downsize than to oversize. So here's number 7, and with this one we still have just a very slight amount of pronation, so we're going to go ahead and use a size 6 stent. So we're going to pull out that trial sizer, and the stent, if you seat it correctly, it's just really hard for that to get displaced. So here's size 6, obviously thread end first. We have that nice angle from anterolateral distal to proximal medial posterior. We're going to get our angle, go ahead and pull the guide wire out so we don't get any problems with that, and we're just going to push that stent in until it won't go in anymore, and then just give it a couple of spins to lock it in place. That's it. We're done. Put a couple of stitches in her skin and she's all set. So here's a patient. You can again just appreciate the excessive deformity because of the obliteration of the sinus tarsi. And here she is post-op. This is 2 weeks after surgery. Nice arch in her foot, fully weight bearing. She was just fully functioning within a few weeks after surgery. So again, here's our pre-op with the excessive twisting of the talus and the calcaneus. Post-op with hyprocure in place. It's just really amazing. Patients do not feel the stent whatsoever. Again, transverse plane, medial column lengthening, and there we are afterward, nice and straight.